And good afternoon, and welcome to Envision New Mexico, Studio Envision. Let's go back one slide here. This is part of our School-Based Health Center Quality Improvement Initiative series, which is really just an all-encompassing series of, they tend to be focused on the school-based health centers here in New Mexico, and we have some that are associated with the University of New Mexico. This is really a fairly generic series on technology, health information technology in general, with a focus on EHRs, their history, and our expectations. And so I'm Kevin Werling, Systems Analyst here at the University of New Mexico's Health Science Center. Envision New Mexico is a part of that. I am certified as a Technical Software Support Implementation Support Specialist, dual role. And I received that as part of a grant. Was able to take that for essentially for free to get this certification. So it's part of the High-Tech Act in quotation marks, which is part of the ARRA. So if you're interested in something like that, anybody who's in IT, let me know and I can get you some more information about possibly taking advantage of that. At this point, so I've introduced myself. Also in the room at the moment, for a few minutes anyway, is...
My name is Michelle Widener. I'm a data analyst here at Envision.
And Michelle's been kind enough to start up the recording software for us today. She's also backing me up as a telehealth support person, among a million other hats she wears here at Envision. So thanks, Michelle. We wanted to see who else was out there. So if you could announce your name and just let me know you're out there, and so you'd be eligible for your CMEs and CEUs or certificate.
Hello, this is Mark at the Southeast Heights office.
Hi, Mark. Thanks for coming back. Looks like you got dropped off there.
No, I hung up the phone when I went down.
Okay, gotcha. No problem.
Okay.
No problem. I got excited thinking there were more people on than I thought. It looks like, Mark, it looks like it's just you and me.
Oh, okay.
And which is just fine, and in fact has been, can make for a good conversation. So if you're game, I'm still ready to present today.
Well, if you're up for it, I am too, so let's just go with it.
Fantastic.
Okay, thanks.
Thanks, Michelle. All right. And we do have another person signed up as well, and we'll see if they show up or not. We are repeating this again tomorrow also at noon, so he may have decided to jump in there.
Okay.
So I wouldn't worry about muting your line unless something explodes or anybody starts screaming or something. I do apologize. We're having some noise going on in the hallway right outside this door. They're recreating an office space nearby us. So if it gets real noisy and you can't hear me, please jump in and let me know.
Okay, the same goes here. We're a WIC clinic too, so you may hear screaming children, but that's just how it goes here. So. Not
a problem. Not a problem. And that's I have a 3-year-old and a 7-year-old, so that's not a problem at all. Totally used to that.
Okay.
And you probably just heard that. So our disclosure and accreditation page, just have to show this for a second. I have nothing to disclose. I work for Envision and that's it. So our objectives today, you'll be able to outline the history of health information technology, HIT, and you'll be able to describe some of the complications involved in HIT and how the complications remain unsolved. At least we're going to touch on these two things. So health information technology components. All of these are components, but really they're components of the first bullet. Electronic health record systems, we refer to them now as EHR systems, and they include all of the things below that. So practice management systems, what you think of as probably an EMR in the old days being 10 years ago. that help you manage your practice, scheduling, making sure that your physician scheduling, your patient scheduling, that sort of thing. Patient portals, if you haven't run into those, they're secure websites that patients can go into to schedule appointments. They can look up their labs. They can do pretty much anything that calling the office and talking to the receptionist can do, but right there online. Home health systems, so blood pressure monitors would be one example of that sends store and forward information to an EHR system. I know sleep apnea masks or equipment have, some of them have store and forward technology in them, a lot of monitoring equipment. Direct care systems as well, so mobile carts, the CMORs that you might see in hospitals and larger practices is where you tend to see them. They're great. They can be used for multiple uses. Telemedicine is one, having a pediatrician in, say, Albuquerque and having the cart with a nurse or an MA in, say, Gallup or somewhere more rural where they don't have a provider available. The provider can do the medicine over the internet using these robots, or they can just be direct care carts that move from room to room in a large practice. EHR systems also include billing systems, which have been around longer than all these other pieces. They're the older part, but they need to interface with all of the payers. In other words, all the HMOs as well as Medicaid, Medicare. Same kind of issue with e-prescriptions. The software out there, it's available. It works. The issue is interfacing with all the pharmacies. As you can imagine, you don't want to just be able to interface with, say, Walmart or Walgreens. You want to be able to interface with everybody, so there's equal availability. Another part of HIT, or a part of EHR systems, is linking up with state and federal registries. This is really more important for the epidemiologists in the world who need to look at the top-down stuff. They need to see what's going on in regions. They need to see what's going on in the state, countries, more of the macro view, the top-down view of, looking at anywhere from asthma occurrences to, H1N1. And then health information exchanges are a part of this as well. They're kind of a part of, and they're a bit external as well. They're really bridges that help EHR systems communicate with each other. So an example would be, if you're traveling, you live in Albuquerque but you're traveling in Nashville, you get in an accident and the doctors in Nashville need to access your records in Albuquerque. Well, those two EHR systems are probably not the same vendor and probably don't speak to each other very well. So these health information exchanges, of which there is a really robust one in New Mexico that's in a pilot program right now, they bridge that gap so you can get the information that you need. And once we get to the point where every system is communicating with every other system, even if we have to use HIEs to get there, that's when we have interoperability. And that's our main goal here. So how we get there, at least how we've attempted to get there from, say, 2006 to this point, is by creating standards and certifications to enforce those standards, essentially enforce as a loose term. The Health Information Technology for Economic and Clinical Health Act, should be in quotes, it's not an act, it's part of ARRA, but the high-tech provision, I guess, would be the word for that. That's what enabled programs like training of IT support people, which that's why I'm here, as well as the incentives to give to providers for incorporating EHRs into their practice, That's where all this came from the American Recovery and Reinvestment Act. The ONC is the one in charge of creating these standards, or at least identifying all the standards and trying to compile them into something usable. There's all these entities that were out there trying to create standards, and as you can imagine, when you get vendors creating standards for each other, that can be an issue. So we really need to be telling the vendors what these standards are so that every system can at least communicate with each other. So why do we need standards? Of course, the whole goal here is one EHR talks to another EHR, and all these things can talk to every pharmacy and every payer and every patient in the country and really the world. But when we pare it down, it's about complications. Networks are complicated. And Mark, are you in IT, or are you, what's your specialty?
Well, no, I'm in health promotion specialist. So I go to meetings, and I'm interested in this topic because of, well, I guess the health information exchange and how that'll be rolled out when everyone enrolls in expanded Medicaid and national health care October 1st this year, as well as the e-prescription and registry monitoring. I sit on a lot of different groups and committees, and one of the committees is the prescription opiate monitoring with the Board of Pharmacy, and I just had questions how that works and if all these entities communicate with each other as envisioned by the Health Information Exchange.
Interesting. Okay. Right. Okay. I see where you're going with that. Cool. Okay. That gives me a little bit more of an idea of how to frame some of this stuff, because if you're in IT, you know a little more about networks than, say, somebody who's not. Okay. Cool. So as far as why we need these standards, really all you need to know is networks are complicated. There's a whole, you can take courses and courses on networking, and they haven't been around that long, about as long as I have. In 1973 is when the first network was created, a computer network. You've got wiring, you've got language, you've got 9 layers of potential issues there. Another part of why we need standards is our language can be complicated. We need semantic interoperability, meaning if one extreme example of that would be if one EHR system defined age as a number, as an age, and another EHR system defined age as a date of birth, those two are not going to communicate with each other. Computer systems are not smart enough to go back and figure out the math and say, oh, this person's 35, this person's 35, I've got the right person.
Yeah.
I don't think anyone's coding that way anymore, but that's possible. And coding is complicated. So those people who are putting in, your coders, putting in your ICD-9 codes at this point and CPT codes, and we're moving over to ICD-10. Which is going to get even more hairy. We've got more digits to deal with and many more codes, and that's certainly not my specialty, but from what I've read, it's going to be a learning curve for the coders. The human error possibility is very high, and we need to catch as many of those as possible. So you need to build in to the systems catches. If someone's diagnosed with asthma and they're not given any sort of albuterol or anything like that, then maybe the system needs to alert you and say, do you want to give out this medication for this diagnosis? That's actually probably a poor example, but you get the idea. Information security and health and safety are on the line here. As I'm sure you know, HIPAA with personal health information you absolutely have to keep that as secure as possible. It's never going to be completely locked down, but you have to do your best. And so keeping that security as tight as possible makes it very difficult for systems to communicate with each other. So you can't just go online and pull somebody's data down. You have to have the authority to do so. And of course the health and safety part of it, you misdiagnose somebody, or you diagnose somebody and you enter it incorrectly, or your MA enters it incorrectly, that could put the patient in danger. And if we could all just agree on one set of standards, that would eliminate most of these barriers, potentially, arguably all of these barriers, I would say most, to information exchange and interoperability. So just starting to get into the history here. The definitions of EHR, they used to be called automated medical records, computerized medical records, computer-based medical records, and now we're calling them EMRs and EHRs. We have definitions coming from all over the place, specifically from the International Organization of Standards, the European Organization for Standardization, that's the CEN. It's a French term, so that's why it doesn't quite match up. The Institute of Medicine, the United States, and then ASTM International. All of these entities and others are trying to define and trying to certify EHRs. And they all have slightly different functional, architectural, and content norms, depending on where they're coming from. So right now what we're doing in the United States is relying on the Institute of Medicine's definitions and certifications. And of course, once again, if we just had one single set of standards, then I suppose we would have a universal monarchy, but we would also be able to talk to each other. So the IOM definition, as it stands, what's interesting here is the series at the end here. So it's really more about, a computer-based patient record is an electronic patient record. That's helpful, but it provides accessibility to complete and accurate data. You can imagine that's a big term to say. Alerts, reminders, clinical decision support systems, kind of like how I was mentioning before. You put in a diagnosis and it might alert you that, oh, well, this person also has this diagnosis, so you might want to do this. Links to medical knowledge, which that is a part of just about every EMR, well, every EHR system now that's certified has to have that linked in, and other aids. So for what it's worth, that's the broad IOM definition. So getting into the history here, and we're not really going to get into specifics on the HIE or anything like that, but I do have some resources that I can give you at the end. And in fact, I don't know if you've spoken with or been in contact with the New Mexico HIT at all, but they're a great resource. They're also funded by the High-Tech Act, and that's why they exist. And that's how I learned about the HIE in New Mexico, was attending their conference last year. So they're a really good resource.
Okay.
And I think I have the link at the end here, and if not, I'll get it to you.
Okay.
So I like to go a little farther back than my slide does, just to kind of give you an idea of how new all this stuff is. We didn't have our first programmable computer until 1936, less than 100 years ago. Then we started building these enormous machines, 30-ton ENIAC machines in 1946. I say machines, it was one. The transistor wasn't invented until 47. Programming languages were systematized in the 50s, And then we had that microcheck reading technology, which is totally unrelated to this, but I think it's cool. That it's been around since 1955, yeah. And it's magnetic printing, basically, that has a reader. And we still use the exact same technology on our checks now. Of course, we're not really using checks as much anymore, but the integrated circuit was invented in '58. And that's when, coincidentally or not, less than 10 years later, the medical records that guide and teach document was released. And I think of it as a book, but it's actually, I was looking it up today, and it's by Lawrence L. Weed, and he was a physician. And his whole thing was to try to get physicians to be more comfortable and more accepting of both computer systems and the use of what he referred to as paramedical personnel. So in other words, your EMTs, your nursing staff, those who are surrounding the doctor. So in other words, it's not doctor-focused medicine anymore. It seemed to change quite a bit as far as attitudes of physicians and how they enter data. It's less, hey, I have this diagnosis because I know this is right, to having to explain why the diagnosis is correct. And that is how you can learn from one diagnosis what you can do on the next diagnosis and the next diagnosis. On top of that, you can see in our modern system of providers that we don't go to the doctor and see the doctor. We see the person at the front desk, we see probably an MA, we probably see a nurse, and the doctor is probably maybe a quarter of that time. So we've really gotten to the point where we're using teams to provide patient care. So that's where we are at. Sorry, I lost my spot. That was '67 was when that was created. And it kind of took off from there. The technology started getting really powerful. Once the microchip was invented, we had our first RAM chip, random access memory, which we have a lot of memory in our PCs now. Back in 1970. Let's see, as far as floppy disk in 1971, and we had our Apple I and Apple II, which actually came out after the first consumer computers, which were the Skelby and Mark 8 Altair, the IBM 510. So, I mean, we could argue about whether Wozniak actually invented the PC or not, but I won't bore you with that. Let's see, what else is interesting here? Our first word processing software and spreadsheet software were in the late 70s, which wasn't that long ago. So this always just kind of boggles my mind that we're at the point where we're at. I mean, we complain a lot about our computer systems and our EHR systems and how they're not working the way they're supposed to, but this stuff has not been around that long. And I think we're doing a pretty good job, although we really don't know what we're doing yet. And that's just kind of the nature of the beast right now. Let's see. Epic Systems in 1983. If you're dealing with EHRs at all, you'll hear about them if you haven't already. Patient scheduling software is what they were known for in the beginning. 1983, the Teresa EHR, or EMR I should say, for direct physician data entry. Your Macintosh was released in '84 and Windows in '85. We didn't have our first EMR for Windows until 1992, which makes sense actually with Windows 3.1 coming out around that time. And this you'll be interested in. 1998, that's when Allscripts launched its e-prescription software for physicians. That's 15 years ago. Very, very new stuff. And they're still around. They're one of the big names in ePrescription. eClinicalWorks was a year later, 99. And 2003, this is when everyone started jumping on board. This is when legislation was being written to get us to try to drive health information technology and try to give physicians the tools and incentives to adopt EHR systems. And that was when Kaiser Permanente, as you may know, one of the largest HMOs since the 70s, chose Epic Systems for its implementation, for all of its physician practices. That was a $1.8 billion deal. And then it was 2006 when all those laws came into place, and we started certifying EHRs. And I'm sorry I got stuck on that slide there. Oh, here we go. So 2006, and this is an interesting number that vendors, creators of EHR systems have 475 certification criteria to deal with. It's not easy to create an EHR that's going to work. Yeah. So it helps, I think it helps to give perspective, you know, that while the vendors, you know, they can be seen as the enemy a lot of times, but on the other hand, you know, a lot of them are really just trying to comply. So we got to try to work with them and not see them as the black to our white, or the enemy to our to us. And 2009, 4 years ago, the American Recovery Act was signed into law, and that's when the High-Tech Act went into place, and the incentives were about to begin. And the Meaningful Use Stage 1 started in 2011, and it sounds like you probably know more about the Meaningful Use stages than I've been exposed to, actually. So, is that something that you've been studying quite a bit?
So no, I'm just here in public health for 3 months since October, so it's all been a big jump in the learning curve.
Oh wow, so, yeah.
But no, I came from, all I know about electronic stuff is I used to work over at the University of Project Echo for the HIV clinic, and it was just very difficult to get physicians from around the state to like present cases electronically because of their, you know, they were really reluctant to use technology because of HIPAA, I guess.
That's interesting. So you know that we're a partner with Echo. I don't know if you were working there when Envision started doing their telehealth program, but just as an aside, that's they used to provide support for us here until I was hired, and now I'm full-time here doing the telehealth program. So so it's nice to meet you, Mark. Let's see. Yeah, the meaningful use stages, it's hard to learn that stuff, and it's really complicated. We do have one of our, she's not here anymore, but she was a nurse practitioner, and she went to work for a practice instead recently. But she and I created a couple of documents that are on our website that I don't know if they're going to be helpful to you, but they might, and they're kind of cheat sheets for meaningful use. So if you want to go to our envisionnm.org website, to the tools and resources, it's under EHR Toolkit. There's not a ton there, but they might be helpful. I don't know.
Okay.
But take a look.
Okay.
And I'm completely open to criticism as well. If you see something there that's incorrect, or that has been updated, then by all means let me know. And that's the other point I wanted to make, is the trick is to try to keep up with all of it, because it changes on like a monthly basis. It's amazing how much meaningful use changes from what you knew a few months ago. It's really tricky. But that's when you got to tap your resources. The New Mexico HIT-REC, which is the Health Information Technology Regional Extension Center, and it's nmhitrec.org. And I believe I have a link at the end here and on our website. They're a really good resource.
Okay.
So 2011 is when we started meaningful use. And the incentive programs are still continuing. They're, in fact, you can still just get started with the incentive programs up to, I think, 2015. You can get started with your stage 1 stuff and still comply. I think you have to fast track it, but the last timeline I looked at, that was the deal. You could go at 2015 and still be in compliance. Sorry, it's getting a little noisy outside the door. Let's see. Oh, okay. So history of the standards. Just a brief one here. The HL7 Health Level 7 organization. They're a not-for-profit, and they're kind of run by the High-Tech Act as well. So they've got a thumb on them. They defined a standard functional model for EHR systems. So all the common functions that all EHR systems should have, and they defined them in 3 different ways. So for direct care, supportive functionality, and information infrastructure. So all the way from the user's interface, the client base, through how the EHR communicates with both the user and outside entities, which is that supportive functionality, bringing in those links that we were talking about, as well as the clinical decision support. There it is, I was looking for it. And then the information infrastructure, that's how the data is stored. So your databases in the background, or those that are, as a server, or, out in the cloud. So they're outlined in those 3 areas. And HL7 also created all these other functional profiles. So you have your base profiles, kind of how I think about it, standard functional model, and then you have your accessory functional models. It's a method for determining the standards for certifying them in the future. So, for example, there's a functional profile for emergency care, child health, behavioral health and long-term care, and regulated clinical research. And I know there are more than that, so those are, I should have an etc. at the end there. So what do we expect from here on out, really the future of EHR? And some of this is current as opposed to in the future. So what is not current is interoperability among all systems. This requires, among standards, we also need, or along with standards, we also need a complete and distinct granularity of all data. In other words, we're not talking about text fields here. We're talking about checkboxes. We're talking about coding. We're talking about single word answers. Single word, I'm sorry, I'm being distracted a little bit by the noise going on out there. Fields as opposed to large text fields that can't be searchable and can't be reportable. That's what makes reporting to the state, like reporting to registries so difficult right now. Is a lot of the older EHRs that weren't certified don't have that ability. They have all their patient notes just in a big text field. They're not searchable by any way, except possibly by keyword, but that's not very reliable in the IT world. You want everything as granular as possible. I'm sorry?
Well, are the old systems, like the initial electronic records, would they just, I'm envisioning like if you had to go back and audit medical records, would there be any advantage to having like the initial electronic medical records versus just the actual old patient files to look at? If you had to go in and pull 50 records and audit it, what would be the advantage of one over the other?
Well, as far as the older EHRs, that's exactly what the problem was, is they held a lot of information, and if you knew what patient you were looking for, and you could pull up their data and it was great, you had everything in front of you and you didn't have to flip through pages and it, smaller storage space. But that's exactly why these standards are being created is everything that we need to report on is not reportable. It's not easy to find all of your asthma pediatric patients in your practice with older EHRs. Even with a lot of the newer ones, it's not that easy. And, or if you need to report anyone who's had a diagnosis of asthma in the last year, so you can do some quality improvement work, that wasn't available. And there's still systems, there's a lot of systems in New Mexico that are in place where you can't get that data. Or if you want that data, you're going to have to pay your vendor to create something for you, to be able to pull that out and to be able to talk to the state registry. It's a tricky system right now. Does that kind of answer your question?
Yeah, I guess it's the what do you call it, interoperability part that's most intriguing, because it would be a great buy-in, but I like your point about everything being so new, relatively new, about electronic health records. I guess it'll be a while or a couple of generations to go before it actually is seamless.
Until it's seamless, yes, definitely. And there's advances that need to be made in not only the HR systems and the registries themselves, but in computer technology, period. Networking hasn't changed a whole lot in the last 20 years. Although it's expanded, which has helped a lot. Which actually, and that's another point to make, is if we're going to have this kind of interoperability, we're going to have internet connections everywhere. It doesn't matter where you are. You can be in rural New Mexico. If you're not on the freeway right now, you can't get cellular service in New Mexico. Or not great cellular service in New Mexico. That just tells you a little bit about what we need to do to expand our technology in every way, from the top down, from the networks to just cabling, along with all the really deep coding that needs to happen. But yeah, I think what the goal is, if we're thinking 2015 as our kind of baseline, that's when we're going to stop the starting of all this, if that makes sense. Then give it 10 years, 2025.
Yeah.
That's a number I've heard thrown around. People have been more optimistic than that. I'm not. I don't think we're going to all be able to get into our patient portal, schedule our appointment, check our record, make sure our phone number's updated, and then be able to check to see if our lab has been fixed or has been completed, and be able to pick up our prescription all online. I don't think we're going to be able to do that for at least a good 5-6 years, and probably longer than that.
Yeah.
But the thing is, we have to get going now, and start getting people to buy into this. And that's a word I heard you say, and the buy-in is a huge factor. It sounds like you've run into that with physicians at Echo.
Well, I come from HIV background, and getting, I used to go to 10 years of meetings to try to convince people that they actually should fill out the forms to submit to the state document and stuff. So I can see the buy-in part being, an incentive would be the records, if it were truly integrated, you could see the options to the patient as far as their healthcare policies that they carry, with the medical options that the physician's presenting and coding while at bedside on the iPad or whatever, and be able to, somebody else maybe explaining the options to the patient as far as co-pays or how, if they've capped out their benefit or whatever too. But
yeah, exactly. And you know what we've had to do here, because we did the same kind of thing, trying to get providers to present their patients. We've gone from even just the semantics of it, not the semantics, but the wording. We don't call them patient presentations anymore. We call them consultations. And we've gotten to the point where we finally have an agreement with Molina that if any physician presents at one of our clinics, and I still say presents, but it's consults, at one of our clinics, and they're a Molina patient, they get so much money. I think it's $150. Don't quote me on that. And we just got that agreement. So that's the line we're going down. We're trying to get it to the point where it's a financial incentive. It's an immediate financial incentive. Well, immediate in coding is never immediate, but you get the idea. And I think that's the direction we're moving. Telehealth in general, telemedicine in general, just one part of HIT, they're not easily billable. You have to add what do they call it, a modifier to some other code. And theoretically, you could add that modifier for doing telemedicine to any code, and it would work. But will you get paid? Probably not.
Yeah.
So I feel your pain. Really, the other expectations that I've listed here, system stability. You've probably experienced this with PCs or Macs. They've gotten a lot more stable. If you had to deal with them back in the 90s, those things crashed on a regular basis. Didn't matter how good your machine was, it crashed. And that's Macs and PCs included. Now Macs never crash, and PCs crash occasionally, and people still scream about it. But they're working a lot better. We have backup systems that work a lot better. Cloud-based systems that seem to behave as long as internet access doesn't go away. Of course, the internet availability. We do have cabling across this state to just about everywhere. Our issue at this point is getting it from the street to the building. So that people can use it. That's where the cost is, and that's where people can't afford to upgrade their systems or upgrade their connections. If you can imagine, if you're dealing with telemedicine, you need a pretty open pipe. You need a pretty fast connection in order to be able to see a patient on an HD camera in real time and be able to diagnose them based on how they present.
Yeah.
Telehealth expansion. There are grants that are being looked at, and some of them have already been fulfilled. But you might be familiar with some of those. There's actually one that's going on right now that we're working on applying for, the telehealth. What is it? Telehealth networking grant, and we're hoping to get that to be able to use kind of the ECHO model actually to be able to bridge people in. So providers who are at a main hospital can help rural area patients through the use of the Seymour robots, whatever brand, but just as a generic term, cameras, and an MA using scopes and trying to diagnose asthma. Asthma is the focus of that.
Yeah.
Real-time interaction with the EHR systems, what I was describing, that EHR utopia, immediately once your prescription is filled, you get an alert on your phone that says, hey, something's happened on your patient portal. You log in there and you see, oh, my labs are done, and I can go pick up my whatever. Hopefully not Vicodin.
Yeah. Well,
that was for you, since you were mentioning the. I think you were talking about reducing opiate use.
Yeah, because I sit on a planning committee for Bernalillo County Community Health Council. It's the opiate summit that they're trying to do in June this year.
Okay.
And they're trying to put something together that they can champion here locally, and actually it's a couple of residents from the preventive medicine program that came up with the solution at last month's meeting. It's just a starting place to get all the information together as far as just a clearinghouse for all of the substance abuse treatment resources. So I think I'm going to advocate for their solution initially.
Cool. That sounds interesting.
And I'm still researching it, but the Board of Pharmacy has the prescription opiate registry or something. And I don't know, I haven't looked into it to see how that reporting's done. But I'm thinking, like, if you had health information exchanges, then people couldn't doc shop to get prescriptions, and so they would eventually, just show up, at least through the payer, receiving all these prescriptions for opiates as well, in addition to the thing. But that hasn't happened so far. I guess they're self-pays or something.
Right. That would be how you get around it, is not presenting your insurance card. Interesting. Is that a state registry or is that a national registry?
Well, it's part of like a national. It's through. I have a guide from I think it's the White House that put out the work plan for it initially, 2009 or something. But I've been going through the State Board of Pharmacy to kind of just look up to see how, if I were the physician prescribing it, what I'd have to go through to record it with them. And I don't know. There's no reports on that particular tab on the website that shows actual monitoring. You just hear about the identification and the Las Cruces physician that had numerous opiate prescription was the one that comes to mind. But that's the only one that I know of that got a lot of press for being initially caught through the system. But that's one physician. But that's one physician in almost 5 years. So there's a lot slipping through the cracks.
Yeah, and it would need to be automated. I mean, we can't rely on physicians going in and just registering every single time they put in a prescription for an opiate. I mean, we'd have to have that pulled directly to really get the good data.
Yeah, self-reporting, I don't know. But like I said, I'm still looking into to see the whole process.
It sounds like it's going through the same stage that we all are. It's really in its infancy. The whole registry, electronic registry, push and pull concept. It's very, very new, so it's going to take a little while. I think the technology is already there. It's partly buy-in, partly financial. We got to get everybody on EHRs first, and then we can get them to report stuff out.
Well, and I was thinking about the Medicaid expansion here in New Mexico. Would probably have a population of about 200,000 that would be qualified, and I can just see them all at the public libraries trying to look up their patient records because they don't have, internet accessibility where they live or anything.
Access. I mean, it's amazing how far we've come and how little distance we've come in a lot of ways. Wow.
Maybe everyone gets a smartphone. I don't know.
Yeah. Could just be issued those when we turn 16 or something. Then maybe.
Yeah. Yeah.
The only other points on the thing here before we run out of time, just wanted to mention, mobile devices like what we're talking about. There's a ton of mobile apps out there for healthcare. They exist, and there's a lot of novel ideas. I attended the American Telemedicine Association conference last May. And probably go again this year. It's kind of a geek fest. You see a whole lot of robots, a whole lot of new and cool devices, but you learn a lot. And if you're into technology and telehealth in general, The point is, though, that there were a ton of mobile apps that were being created for telemedicine specifically. One in particular was created by I believe for the VA, but it was for veterans, and it's mostly a behavioral health kind of app. It's a check-in. It not only reminds the patient to take their meds or that they have an appointment coming up, but it does a check-in with them, and they're supposed to go in and type a note to their physician and say, yeah, I'm doing well today, or I'm not feeling so hot, or I'm depressed today. Just some really novel ideas that are coming out of that, and I think we're going to be seeing them out in the real world here. It's not going to take long. These things take off pretty quickly. You saw how fast the iPhone took off just by itself. Things like wearable computers, implantable chips, we've already got these things. Projected keyboards that work by touch, and touch screens. If you saw Minority Report, we're basically there. We're doing that already. Now, of course, you'd have to pay $1 million to get one of those, but they exist. Yeah. It's kind of amazing. And then patient direct input. This is in place in some EMRs already. This is only at the end because I added it this year. That you go into a physician's practice and you're handed, or you walk up to a kiosk and type in your information. You can fix your if your date of birth is wrong or something, you can fix that. Say why you're there, and then you go and sit down. As well as the whole patient portal concept of scheduling your appointment without having to call and be given 2 possible dates that you might be able to see the doctor. You can see his whole calendar and sign up for whichever one works for you. And to me, that's incredibly appealing. So that is the information that I had for today, and we timed it pretty well. Let's see, the one at the bottom there, that's one I would recommend to you if you haven't contacted them yet or looked at their site. Their website doesn't tend to update very often, so if there's a question you have for them about the HITECH Act or anything with health information technology, just email them, and their contact information's on their site. They tend not to update it as much as it seems like when I go there's not a lot going on, but I know there's stuff going on. So I would just contact them. Let's see. I'm sorry, did you need that?
Yeah, I think I downloaded the copy of the...
Oh, good, okay. One that I don't think was in that copy that you downloaded is the second one here, which is information on certification of EHRs. I don't know if you're interested in that or not, but if you have an EHR system and you don't know if it's certified or not, you go there and you can look it up and see if it is. And then the New Mexico Health Information Exchange, HIC, I think is not correct. Hang on one second.
It's
I think I've got
HIE.
That would make more sense, right?
Because when the health department had their last webcast in December, they had a big presentation on the update of the HIE, and they were all excited about that. So it may be one of the best things to come out of all this.
Gotcha. Oh, the Health Information Collaborative.
Okay.
Let's see. And they're related to the HIT as well. Yeah, this is where you want to go.
Okay.
So it is NMHIC. Although they seem to have a security certificate issue on their website, just say you probably saw.
Yeah.
But that's them. There's more information on the standards too, if you ever want to dig more deeply. Right here, skmtglossary.org. Wow, I'm typo happy. Apologize for that.
Okay.
right. And I already know you're here, so you don't need to say your name. Very good. So I did want to mention before we run out of time, I don't have it scheduled yet, but I'm planning on doing a couple more of these, getting a little more specific. The part 2 is going to be EHR components, so more on the pieces that make up an EHR system, nuts and bolts. And that'll be next month, probably towards the end of the month again. Okay. Part 3, I'm planning on doing a why are we doing this kind of webinar? What's the point of it? Why are we using EHR systems? Which I think would be useful for someone like you who's trying to help with buy-in. So maybe we can learn a little bit from that one, from each other. And I may do a part 4 that I did last semester that didn't seem to really be applicable to a lot of the participants, which was EHR implementation strategies from an administrator's point of view, and of course I have my point of view from an IT perspective, so you get a lot of that if you're prepared. And so I may do that, I may not. It didn't really help because most of these strategies are for large organizations, and most of the participants were working in either school-based health centers, some of them were school nurses, or they were small physician practices. They didn't really apply to them. So I may or may not do that one, but if you yourself, or if any of your colleagues have something you want a presentation on, please feel free to send me an email and let me know, and I'll be happy to, if I can do it, if I have some sort of knowledge on it, then I'd be happy to present on it.
I appreciate that.
Well, I appreciate you coming, Mark.
Okay. Well, I'll look through the schedule and register.
Sounds good. Yeah, and I don't have it up there yet. I apologize, but it'll be towards late February, and I should have that up this week sometime.
Okay. Thanks so much.
Excellent. Thank you. Appreciate it.
Okay. Bye-bye.
Bye-bye.